So I think,
okay, so we start, huh?
Yeah.
So this is your first slide?
Yeah.
Okay, so hello, my name is Etienne Burde. So I'm professor in human robotics at Imperial College London. And so this is the beginning of this symposium, this workshop on three-hand surgery within the Hamlin Symposium. So there will be four speakers. Four speakers. Three of them are here, and one could not join in person and has sent a video. But we will be able to pass question. So what is three-hand surgery? So the idea come from two sources. So one source is that, for example, in the Da Vinci system, you have three robots, or you have in many robot-assisted systems, you have tools and you have, for example, the camera. And so you would like to manipulate all of them. And so there are some engineering solutions, for example, with clutch or with switching control, but it may not be ideal. So this is one thing. The other thing is that, so we thought about augmenting human, and then we looked at, in fact, there are humans who are augmented relatively to us with normal limb. So for example, you have people with 6 fingers, so-called polydactyly. And so we did study such people to understand a bit what is the limit of the brain. So whether the brain could control more than our normal body. And what we found on these people is that, in fact, they are more clever than us in the sense that they can manipulate objects in a more sophisticated way that we can with 5 fingers. So from that point of view, it seemed to be possible that you can use more than the limb you have normally. So your brain would be able to do that. Now, what is interesting, so we started with, Ella had to work on that. So she looked at, doing her PhD, she looked at whether you can control your feet and hands simultaneously. And Yante did also her PhD on continuing this idea and on more surgery. So you see, for example, so this idea, so on the screen, so you have a slave robot with 3 or 4 tools, and you would have 4 hands to manipulate that. Of course, you don't have 4 hands, but a simple solution would be to use, for example, the feet. Another solution that we will not go into in this workshop is to use some control from the brain or from some signals that we can extract from EMG, from the muscle activity. And so, for example, on the right, you would, so this is an artist illustration of what you could do. So you could extract electrical activity from the muscle, and from that get richer signals that we normally use to control the body, and use some of them to control an additional robot. And so this is the concept of three-hand surgery. And so the speakers, so we start with Eli Habdi, who is assistant professor at Monash University in Australia, in Melbourne. And so she did the PhD at EPFL on the understanding how you can combine 3 limbs. After we will have Dr. Khan, who is general surgeon in Singapore, and so she's also affiliated with NUH, and so the National University Hospital in Singapore, and she will give us insight about what can be useful for three-hand surgery in real surgery. After it, we'll have a break. After the break, Professor Guillaume Morel will speak. He's working at IRIS, so he's directing IRIS, who is an institute with a lot of robotics, all kind of robotics, and he's working for a long time on robot-aided surgery, how to improve that. And we will finish by Dr. Yanpei Yuan, who is a research associate in my group. And so, as I told, so she worked on developing three-hand surgery for and some application, and she's continuing this work. So I will finish by saying that with Guillaume Morel and Yanpei, we are also in a European project that is called NIMA, and this is about human movement augmentation and some application in surgery. And then I think we will start with Elahe, so you can, you can share your screen, and thank you very much for participating. I hope it's not too late in Melbourne, but I know it's not too late because in fact I'm just coming back from Melbourne. I had not from Melbourne, but from Australia. I was this morning in Australia virtually.
Okay, interesting. Okay, thank you very much, Etienne, for this introduction. So let me start the presentation mode. All right.
Yeah.
Okay, so
you see very well.
Okay, great, thank you. So thank you for the introduction and thank you for having me in this interesting workshop. Today, I'm going to focus on one line of research in my team, focusing on commanding the laparoscope in keyhole surgery. And in line with what Etienne mentioned, I'm going to talk about how we can directly control a robotic third arm for controlling the laparoscope in surgery. And also I will talk about some of the opportunities that exist for inducing some autonomy into the system. So this research is motivated by the need for assistance in different types of tasks. It can be a task in industry or medical applications. My presentation is going to focus on surgical applications. However, the results are also applicable for other domains as well. So starting to look into keyhole surgery, this is a type of surgery in which you have some small openings on the patient's abdomen, and the surgical tools are inserted into the abdomen through those small openings. Because the direct line of sight is lost in this type of surgery, it is important to have a camera, namely the laparoscope, present in this among the instruments, so that the surgeon can see what's happening in the surgical site. So the main surgeon holds two of the main surgical tools, and then the assistants hold the laparoscope in addition to other possible tools that are required for the surgery. This is how a typical operating room looks like. As you see, we have a number of assistants present, and then at least two of them here are helping the main surgeon holding the laparoscope and other surgical tools. So you can imagine that there might be some communication errors between the main surgeon and the assistants, and holding the laparoscope for long hours can be actually quite tiring for the assistant. On the other hand, there are some type of surgeries, such as, for example, the appendectomy, in which the surgery is very simple, that it can actually be done by only one surgeon if they could hold and handle more instruments on their own. So with this background, we are motivated to look into development of a robotic camera control unit. Hereby, I'm going to reference it as the RCCU for commanding the laparoscope in keyhole surgery. And this is to have a surgeon who is more autonomous and dexterous and can handle more tasks on their own. So I'm going to give you a bit of background about how RCCUs are controlled in literature, and then I will focus on the possibility of using the foot for controlling the RCCU as the third arm, before talking about the foot interfaces that we have developed dedicated to this task, and also talking about the potentials for shared autonomy in the field. So this robotic camera control unit can obviously be controlled by hands, which means that you can have like some type of joystick for controlling the unit. However, it means that the surgeon needs to let go of one of the main surgical tools and use this joystick for the command. That's why hands-free strategies have been introduced. These can be something such as the foot, the voice commands, facial gestures, or head movements. All of these different control strategies have their own limitations. Most of them can only activate 3 degrees of freedom. They might be a source of distraction for the surgeon because they need to divide their attention between different tasks. And it might interrupt the main task as well, especially in the hands-on scenarios. So let's have a look and see if it's possible to use the foot for controlling the robot camera control unit in an intuitive way without distracting the surgeon. So to look into this, I started my PhD at EPFL with collaboration with Etienne and at Imperial to look into the possibility of using the foot and the capabilities of the foot for controlling the RCCU. I started my experiments with some virtual studies. You're seeing one example here in which we have a couple of virtual hands on the screen. The 2 gray hands are controlled by the 2 hands of the participants, and the yellow middle hand is controlled by the foot. The participants are asked to complete different types of tasks. For example, here, they need to catch the falling objects on the screen before they reach the bottom of the screen. The aim is to see whether people will prefer to use their 2 hands or 3 hands and what type of tasks they will be comfortable to use the 3 hands in. In these experiments, the participants sit at a desk and 2 Kinect cameras detect the movements of their foot and the 2 real hands. And then these movements are mimicked in the virtual environments using the virtual hands. So the results show that once the task becomes demanding, as you can see in the left diagram, less effort is required when they use the 3 hands compared to 2 hands. And again, once the task becomes demanding, they prefer using the 3-handed scenario. So they also find it less mentally and physically tiring. In another set of experiments, I could also see that people use their 2 hands and the foot randomly. It means that they are not grouping their 2 hands and the foot separate from each other, which is a good news. The other good news is that there is a rapid learning effect, and within a few minutes of practice, participants actually get much better in performing the tasks. So these experiments were conducted mainly with engineering students. So as the next step, I moved to the Hospital of Sick Kids in Toronto, Canada, to conduct some experiments with surgeons and medical students. In these experiments, still in virtual environments, I developed a new environment which is closer to what surgeons see in laparoscopic surgery. The hands of the participants were modeled as surgical tools, and they could use their foot to command a virtual camera in 2D. These experiments were conducted with 53 surgeons and medical students. And as you can see in this graph, the different cohorts of participants ranging from medical students all the way to experienced surgeons were better in different objective measures of performance. For us to have a better understanding of who is the best performer, I introduced the foot-hand coordination factor, which is actually a combination of all the objective measures that we had in experiments. And as a result, I could see that the residents are the best performers, and thus the residency is the best time for 3-handed task training if we want to introduce this type of strategy into their hospitals. So with this background, I embarked on a journey to then develop some dedicated foot interfaces, which can be used for controlling the robot laparoscope holder. The idea is for the surgeon to be able to hold the 2 main instruments by their 2 hands while they control the laparoscope using their foot. In the first developed prototypes, I had two main questions to answer. The first one was that whether an isotonic or an isometric foot interface is a better option, and also whether a position control or a rate control is more comfortable. This is the prototype developed. This is an isotonic interface, and it was dedicated to position control. We need to control 4 degrees of freedom for a laparoscope. It's insertion and withdrawal, and the 3 degrees of rotation, as you see on the right-hand side of the slide. And this is supported by this interface by the planar movements of the foot forward and backward and to the right and left, and also the 2 rotations of this plate here. As you see on the figure on the down left, the foot is placed on this pedal, and then 2 degrees of rotation are supported by this pedal. The second prototype is an isometric prototype. Here, when you put your foot on this pedal, you are surrounded by 6 push buttons, which support the actuation of 3 degrees of freedom. And then the whole platform itself can also rotate, which provides the 4th degree of freedom. And this interface was used to test the rate control, meaning that we could actuate the movement of the robot controlling its velocity. A comparative study between these 2 interfaces showed that the isometric interface is actually preferred, and there is 2 main reasons for this. First of all, the other interface was tiring because of the foot movements that participants had to do. And also, the position control can potentially limit the movement accuracy of the robot, especially if the workspace of the foot interface is much smaller than the workspace of the robot itself. So with the learnings that we had with these first prototypes, my research assistant, Mr. Shangju Ye, and PhD student, Mr. Yanjun Yang, started the design of 2 new interfaces at Monash University in Australia. Here is the 3rd interface, which is actually a combination of the previous 2. So you put your foot on this pedal, and then there are 2 sets of push buttons at the front and back of the foot. This pedal can also rotate, and it can translate to the right and left. So we still have the 4 degrees of freedom. And the final interface has some infrared sensors to detect the planar motions of the foot. The middle plate can also rotate, introducing the 3rd degree of freedom. And we have a push button, which, if actuated, will change the application of the middle plate and introduces the 4th stuff as well. In the evaluation of these 2 interfaces, we wanted to answer another question. And that question is that how these interfaces work in comparison to some of the other commonly used control paradigms. One interface, like the 3rd prototype that we developed, is compared with the conventional pedals. Since we need to control 4 degrees of freedom, we have like 8 pedals on a planar surface, and we wanted to compare the performance of these 2 interfaces. In this video, you can see how this foot pedal works. As you see, this pedal can actually control the robot in 2 different velocities. The high velocity is mainly useful for reaching the target faster, while the lower velocity is useful for more accurate movements. So we could see in these experiments that using the developed foot interface compared to the conventional pedals is actually less mentally tiring, and participants need less visual checks for the location of the foot compared to the conventional pedals. And also, they were faster in completing the different types of tasks that they had to do using this interface compared to the conventional method. And we compared our final prototype with the other main competitor, which is using voice commands. And we could see that almost all the participants preferred using this interface and found it easier to control the camera movements. So in the last part of the talk, I want to talk about some of the potentials for introducing autonomy into the system. So we talked about the fact that we need to control 4 degrees of freedom for a laparoscope. And although we have been looking into development of some intuitive interfaces, it is still an increased workload for the surgeon. So to deal with it, our suggestion is to introduce some level of autonomy into the system. We still don't want to go for full autonomy because of safety considerations, but we want to be able to reduce the mental load for a surgeon. So to control the laparoscope view, first of all, we need to have a good understanding of what an optimal laparoscope view is. Here is an example of an optimal view. As you can see, we have the tool tips visible on the image. We have the target and also a bit of information about the environment. And obviously, the image should also be stable. To achieve such an optimal view, one approach is to look at the tools and try to keep them into the view at all times. To achieve this, there are 2 main approaches introduced in the literature. One is to add a tracker to the instrument so that it can be easily followed using the laparoscope. And the other one is to use neural networks to identify the instruments. The neural network one is a superior approach because it doesn't need any additional accessories. However, the literature so far just focuses on some simulated images rather than real surgical videos. So our aim is to just focus on automating the zoom ratio. The other 3 degrees of freedom will still be commanded by the surgeon. And even the zoom ratio can always be overwritten by the surgeon if they want to. To quantify the tool view ratio, here is our suggestion. So we use neural network to segment the tools, and then we measure the length and the width, and then we introduce a ratio, which is the length divided by the width to the power of 2 to characterize the tool view size ratio. This ratio is a good option because it considers both the tool size as well as its shape. And also it returns a unique value for different situations. So for each zoom factor, you are going to have a unique ratio, and it will be helpful to adjust the zoom ratio whenever you want. So our idea is that with this approach, we can find a range for the acceptable view in the surgery. So we have tested this approach on 80 videos for gallbladder removal. And these are real videos from surgeries. And you can see that we can actually find a range which is acceptable for this ratio, for example, for the clipper during this type of surgery. And then the idea is to be able to use this to then control the laparoscope, which is going to be our next step. So to conclude, you can see that commanding the 3rd arm by the foot is actually feasible. Rate control is preferred over another approach, which is the position control. If we can have a foot interface with low physical and mental burden, it can actually be perceived even better than voice commands or a conventional foot pedal. And also, finding the optimal range for main instruments in the surgery, such as a cutter or clipper, provides a good opportunity to introduce some autonomy in surgery. Thank you very much for listening. I'm happy to take some questions.
Thank you very much, Elahi. Thank you very much for the insight. So there was actually one question that is about the delay in your device and how can the surgeon overcome the delay?
let me see. Okay. So the delay is something that's actually very manageable. So currently in our system, we have 0.2 seconds of delay. And it's actually something that we have introduced in the system for safety reasons, because we don't want to have some unwanted movement in the robot if the movement of the foot is unintentional. Other than that, depending on the robotic system that you're using and depending on the controller, you can actually have a good grasp on the delay in the system.
Okay, there is another question that is, okay, so if the foot is controlling the robot arm, so the doctor can't move. So do you have any comment on that?
Yeah, so I guess that's a very important point, and that's true. If the doctor wants to control the laparoscope, they need to be at a certain point where the interface is. So that's true. However, in the surgical observations that I have had, sometimes the surgeons move and sometimes they are standing at the same position. So it's a trade-off, but it's definitely a limitation for this approach.
Okay, so I have a bit more insight in that. I mean, connected. So in our project, we look at alternative way to comment where you, for example, you would use degrees of freedom orthogonal to your movements or orthogonal to your signal. So that's something that is in development. So of course it's practical. So if a surgeon is sitting to just use the foot, but now it's also possible to develop alternative ways. Any other question of the audience? You can also, so you can write it.
Yeah, I will ask one question if I can, if I may. Do you hear me?
Yeah, great.
Oh, okay.
Yeah.
So the question is about the importance of having this foot resting or having the feedback of the force you apply. Have you tried to use like contactless interfaces just to see how important it is to be in contact with the controls and having this sort of feedback on the foot?
Yeah, so it's something that we are doing right now, like just tracking the foot by a camera and having some trackers on the foot, and then compare it with having the tactile feedback as you were mentioning. So my intuition is that it is important to have that, and it's the reason that I mentioned that people needed less visual check of their foot, because they could feel what's happening. If we don't have that, I'm assuming that again they will need to do more visual checks, especially at the beginning. But it's something that we are looking at right now.
So there is a very interesting question, that is, did the surgeon offer ideas? Elahe, do you have, so in your project, did you get ideas from surgeon or did they contact you? And yeah.
Yes. So when I was doing this research at EPFL, I had a co-supervisor at SickKids. She was a pediatric surgeon and she certainly provided inputs. And currently we are working with another co-supervisor for my PhD student at the Alfred Hospital in Melbourne. And they provide very valuable feedback. Yes.
Okay. Any other question? No. Then we go to the next speaker. So Yanpei, who is the next speaker?
Next speaker is Dr. Kang. So I will
Okay.
show her video. Okay. So unfortunately, Dr. Kang cannot join the workshop in person due to some reason, but she has pre-recorded her video. I will share my screen.
Yeah.
Very good morning, and thank you to the Hamlin Symposium for having me. I understand that the majority of the audience is made up of engineers, and from the years that I have been working with my engineering collaborators, I realized that a lot of the surgical knowledge that they pick up is actually from YouTube or from Google. So because of that, today I would like to approach my talk by describing surgical gems that you will not be able to find in standard surgical textbooks.
So just interrupt a bit. Can you see the video? You guys see the video well?
Yes, yes, we can see it now.
Even less so on YouTube or Google. It is my belief that the many years of surgical training and experience allows a surgeon to crystallize important surgical truths and identify real clinical needs. I hope that my lecture today will inspire you to come up with outstanding technological inventions to address the current gaps in surgical practice. First, I will briefly explain how surgery has evolved over the last century, and then explain where the current gaps are in surgical practice. To understand these gaps, we must first comprehend the basic tenets of surgery, the typical operating theater setup for different types of surgery, and the minimum number of people required for each procedure. Towards the end of my lecture, I will also briefly touch on how my research group has been using robotics to bridge clinical gaps in therapeutic endoscopic procedures and natural orifice transluminal endoscopic surgery, also known as NOTES. Let's talk about the evolution of surgery. Surgery began in the form of open surgery, a highly invasive procedure where the surgeon makes a large incision on the patient's abdomen and uses both of his hands to directly dissect, manipulate, and repair tissues. In the 1980s, laparoscopy was introduced as a minimally invasive procedure where only a few incisions ranging from a size of 5 millimeters to 1 centimeter were required to allow the surgeon to gain access into the patient's abdominal cavity. But the downside of this is that the surgeon is now unable to feel and unable to touch the tissues. Instead, we have to use rigid laparoscopic instruments to manipulate and dissect tissues. So as you can imagine, these laparoscopic instruments do not have flexible tips, and they are really a very poor substitute of our delicate and complex human wrist. Also, the surgeon is now no longer able to look directly into the abdominal cavity and have to rely on the laparoscope to replace what the human eye actually does intuitively in open surgery. In 2000s, robotic surgery was introduced with the hope of allowing the surgeon to control all the operating arms by himself without having to rely on assistants to operate additional arms. Also, it allows the surgeon to operate remotely without necessarily being in the operating theater.
Yampe, you're muted. Sorry, can you unmute?
Yeah, we cannot hear it anymore.
Endoscopy was introduced, and surgeons were only able to visualize the insides of the gastrointestinal tract without being able to perform any therapeutic procedures, even if lesions such as polyps were identified. But by the 1980s, more endoscopic instruments such as the biopsy forceps and the endoscopic snare were invented, and these instruments allowed surgeons to perform interventional procedures such as resection of polyps. However, there is a limit to how much intervention the surgeon can actually perform during the endoscopic procedure. Endoscopic instruments are rigid and cannot be rotated. Also, the traditional endoscope has only one instrument channel, and that means that if you are performing a therapeutic endoscopic procedure, it is similar to performing surgery as a one-arm surgeon. Surely that is suboptimal, and hence results in low success rates and high complication rates. Now, what surgeons have tried to do in the past few decades is to use the endoscope to perform more advanced surgical procedures through natural orifices, known as nodes. If nodes is successful, the patient then goes home without any visible surgical scars, which obviously minimizes post-operative pain significantly, and patients can then return back to their normal life at a faster pace after surgery. The problem then is that, as good as note sounds, the current endoscopic instruments really do not allow surgeons to perform complex dissections and tissue manipulation. However, robotics can solve this problem, and I will touch on this area towards the end of my lecture. Before we jump onto the bandwagon and get excited that three-hand surgery is the next big thing, it is critical that we first understand the basic tenets of surgery and how these principles have been preserved throughout the various types of surgical procedures. First, optimal tension must be applied through retraction. In this photo, this silver surgical retractor is used to widen the surgical incision. The second principle is that the retraction must allow for adequate exposure of the operating field. So in this photo, the retraction allows the surgeon to visualize the vessels and the nerves that are deep within the operating field. As developers of technology and devices that allow for three-hand surgery, I hope that you will always bear in mind that the third hand is often used for retraction, and this third hand must be able to provide optimal tension during retraction so as to provide adequate exposure of the operating field to the surgeon. Now, let's look into the typical operating theater setups for each type of surgery. Again, what I will be sharing in the next few slides cannot be found in any surgical textbook, YouTube, or Google, and these are really the gems that a surgeon accumulates after years of experience. What I will aim to show in my following slides is the setup of the theater, as well as what each person in the team uses his hands to do. From there, I will show how a surgeon needs at least 3 or more hands if he wishes to perform a surgery all by himself. In open surgery, the surgeon typically stands on the right side of the patient. He uses his right hand to operate and his left hand to provide traction by handling tissues. The assistant nurse then uses her hands to pass surgical instruments and gauze to the surgeons. Now, there's already a total of 4 hands required for the surgery, but that is not sufficient. We still require the first and the second assistant. The first assistant has a multitude of tasks to do: perform hemostasis, move the surgical lights to focus on the operating field, expose tissues for the surgeon to visualize the site of dissection, follow the suture when the surgeon is suturing, and cut the suture after that. The second assistant then mainly does the task of retraction using both his hands. With this operating theater setup for open surgery, you can see that it already requires 8 hands for a surgery to go smoothly. It's no wonder then that surgeons wish to become Dr. Octopus. In laparoscopic surgery, the surgeon again uses both his hands to operate and provide tissue traction. Importantly, remember that in laparoscopic surgery, the surgeon is unable to visualize within the abdominal cavity. That means that his only source of visual input is the laparoscope, and this laparoscope is maneuvered by the first assistant who stands beside him in the surgery. The role of the first assistant is exceptionally important as he is literally the eyes of the surgeon. As a human being, we are able to look up, down, left, and right, and even sideways when we tilt our heads. But the laparoscope is not smart enough. If you want to look up, down, left, right, you have to maneuver the laparoscope. And if you want to look sideways, you have to rotate the light source. You can imagine that this is a very challenging task, and many surgeons will be able to recount to you their endless frustrations with first assistants not being able to show them the vision that they desire. The second assistant stands opposite the surgeon, and again his main role is to perform retraction to expose the operating field to the surgeon. The assistant nurse then passes laparoscopic instruments to the surgeon. Again, with laparoscopic surgery, we need at least 8 hands for the surgery to go smoothly. Now, in robotic surgery, things are very much different. The surgeon can now operate, provide traction, maneuver the robotic arms, and switch between the robotic arms all by himself. He no longer has to rely on the first assistant for vision or the second assistant for retraction. In robotic surgery, the first assistant and assistant nurse has very little contribution to the actual performance of the surgery. Because the robot can perform the role of the surgeon and multiple assistants simultaneously, the number of hands required in robotic surgery drastically decreases, and the surgeon is really the only person that is important for the surgery to go smoothly. For interventional endoscopic procedures, the surgeon uses one hand to hold the endoscope and the other hand to maneuver the endoscope and manipulate the endoscopic instrument in the single instrument channel. The nurses then help to pass the instruments to the surgeon and monitor the patient. Here, the number of hands required is small, but remember, performing interventional endoscopic procedures using current endoscopic instruments is highly ineffective, as the surgeon is really just operating as a one-handed surgeon. From what we have discussed, let's now look at the minimum number of persons required for each procedure. This is a summary slide showing that the minimum number of hands required for a procedure is at least 3, and that can only be achieved when robotic surgery is performed. I hope that this knowledge can then reinforce the idea that the third hand in surgery really performs retraction of tissues to expose the operating field to the surgeon or manipulates the camera to provide vision for the surgeon. This brings me to the second half of my lecture today. Now that we know the limitations of current surgical practice, let me share with you what my research team has been working on to address these limitations. We believe strongly that robotics can help to bridge this gap. The use of robotics allows surgeons to perform therapeutic endoscopic procedures and notes more easily. Let's talk about therapeutic endoscopic procedures. As I previously mentioned, there is only a single channel for insertion of endoscopic instruments, and that means that surgeons have to contend with being a one-armed surgeon when they perform therapeutic endoscopic procedures. And to make things worse, these instruments are rigid and lack degrees of freedom. All in all, the current technology for endoscopy seriously impedes the surgeon's ability to perform therapeutic endoscopic procedures well. Now, how can robotics overcome these problems? Well, we use the flexible robotic endoscopic system, which is equipped with multiple robotic arms. That means that a surgeon can now use up to 3 hands in the therapeutic endoscopic procedure. Additionally, these robotic arms have multiple degrees of freedom, which effectively mimics the complexity of a human wrist. The flexible robotic endoscopic system that we use is known as EASE, Endoluminal Access Surgical Efficacy System. This is currently being manufactured by Endomaster. The robotic endoscope has 2 robotic arms that are interchangeable, able to rotate and have 9 degrees of freedom. To a surgeon, that effectively means that I am now able to achieve triangulation, superior tissue retraction, and importantly, optimal exposure of the operating field when I perform therapeutic endoscopic procedures. Our research team has also developed a suturing device that can be used with the robotic endoscope. It consists of a needle holder as well as a grasper. The needle holder is preloaded with a suture needle. The needle holder has 5 degrees of freedom, and the surgeon is able to lock and switch the suture needle between the jaws of the needle holder. This design mimics the arms of a surgeon performing suturing. Clinically, this device allows surgeons to perform surgical suturing endoscopically and minimizes the need for surgical interventions should complications such as perforations occur. This video shows how the suturing device works. Both arms of the robot is first inserted. The right robotic arm is the needle driver and the left robotic arm is a grasper. Both robotic arms can be rotated. And now we are loading the suture needle into the needle driver. And then switching the needle between both arms of the needle driver. Subsequently, the guide wire is removed and the suturing device is ready for use. Notes is another potential application where robotics and a third hand can hugely benefit the surgeon. Currently, when we perform notes, we use mainly laparoscopic instruments. However, because they are rigid, we are unable to intubate the entire gastrointestinal tract, and it is near impossible to achieve the triangulation and retraction angles required for tissue dissection. That translates to the need to insert additional laparoscopic trocar sites to create multiple arms. At the end, a pure notes procedure is not possible, and we often have to contend with performing a hybrid laparoscopic notes procedure. Again, how can robotics overcome these problems? The robotic endoscope is flexible, and it is able to intubate the entire gastrointestinal tract. And the robotic endoscope has up to 3 working arms, and that allows the user to perform 3-hand surgery without the need to insert additional laparoscopic trocar sites. Here we perform an ex vivo notes appendicectomy using the flexible robotic endoscopic system. We first start by creating a full thickness perforation through the wall of the rectum. This is an external view of the full thickness perforation. We then retract the appendix using endoscopic resolution clips. Next, we create a mesoappendix window and secure the appendiceal artery using endoscopic resolution clips. And the artery is then divided. The remaining mesoappendix is divided as well. The retraction of the appendix is then removed. And the base of the appendix is secured using endoscopic endoloops. The base of the appendix is now divided. And the resected appendix is retrieved. The full thickness incision at the note entry side is then closed using multiple endoscopic resolution clips. And this is the external view of the closed notes entry site. We perform a successful negative air leak test, demonstrating that our closure of the notes entry site is secure. So this brings me to the end of my lecture, and I hope that what I have spoken about today will really inspire you to think deeply about what a third hand in surgery should aim to achieve, and the types of surgical procedures that will benefit the most from having a third hand. I regret that I'm not able to be present on Zoom today to engage in a question and answer session with you, but please feel free to send me an email if you wish to collaborate or if you would like to have a surgeon's input regarding the technology that you're working on. Thank you very much for your attention.
Okay, so thank you, Dr. Ken's presentation. So if you have any questions, you can contact her through her email. I will also send her email in the chat.
Yeah, otherwise I think we will continue directly with a presentation of Guillaume.
Do you mean you want me to start now?
Yeah, I think the schedule is a little far behind. I think we may don't have the break and continue the workshop.
All right. I suppose you can hear me.
Guillaume, if you can put in projection mode. Yeah, that's perfect. Thank you very much.
Oh, well, thank you very much, Etienne, and thank you for inviting me for this very interesting workshop. So my name is Guillaume Morel. I'm a professor in robotics at Sorbonne University, and I will present you the work that we are doing here at ISIR in controlling a third hand for laparoscopic surgery. So I realized that the beginning of my talk that I prepared has been already largely explained by the previous operator. So I will go very fast to remind that the context is laparoscopic surgery, where we have a surgeon with a right hand and a left hand holding instruments penetrating inside the patient. Meanwhile, a second surgeon holds a camera that gives the visual feedback to the surgeon. Okay, so this is typically the three-hand configuration that was explained by previous speakers. And we also acknowledge that for about 20 years or even more, there have been several solutions in the operating rooms to hold endoscopes. Here you have a French system that is called Vinci. Here you have a German system that is called Solo Assist. And they can be manipulated by the surgeon. So the surgeon still has the instruments and has to deal with this guy. So again, this was already explained, so I'm skipping that. As mentioned by previous speakers as well, literature and commercial products use many different kinds of control approach. The first talk was a lot about foot pedal, but some of them are controlled by voice, by hand joysticks, by head orientation, and again, if you go into research paper, you will find many different approaches. And the general idea is to use freehand teleoperation. So having your two hands manipulating the instrument and being able of manipulating the third hand through teleoperation. Little papers are found that compare all these approaches and evaluate them comparatively. And this was a bit our aim in the study that I will present today. And for this, we have been using an experimental platform that is here in the lab. It's called Surgical Cockpit. It has 2 or 3 arms. Here, this is the 2 arms configuration, where you have one arm holding an endoscope and one arm holding an instrument. These arms are made with the technology of haptic interfaces, meaning that they are very transparent, very backdrivable. So if you set up a 0 force, you can manipulate completely freely the instrument. Plus, you can add forces either to maintain the system still or to move endoscope or instruments. So they can be active or passive, very easy. So we will be using this system throughout the study. And the study was made from the perspective of human-machine interaction, meaning that what we want to evaluate is what is the potential of this sort of interaction or the other sort of interaction. So the study was conducted mainly by Ignacio Avellino and Gilles Bailly, and several others contributed. And it was divided in 2 phases. In the first phase, we were showing videos to surgeons, illustrating the different modes of operation, and through interviews, asking them how they would feel with those different options. Then we selected 3 modes out of those interviews and implemented them on the surgical cockpit, and had more surgeons coming and trying the interaction, and again giving their opinion on that. So for the first study, what you see here is accelerated the video that was shown to the surgeons to explain them what could be the mode of interaction. So we have the baseline mode, it's moving the endoscope with the hand. So maybe I can just show that, okay? So here, this is an actor, and he shows how to move the endoscope by the end when you release one of the instruments. So he releases an instrument and move it. This is the baseline control of the endoscope. The second one that we wanted to show is posture tracking. So as you can see, the actor here moves, changes the posture, and we attach in a position way the movement, the position of the endoscope holder. The third mode is to use a joystick. This is sometimes used in some commercial products, to use a joystick here attached to the instrument and control the endoscope position thanks to that joystick as shown right now. We had a 4th system, which is force sensing. So with this system, the endoscope holder is locked with a high stiffness, and when the surgeon moves, it creates a velocity on the endoscope. Okay, so it's the force to velocity paradigm between the instrument and the endoscope. And the last mode is not a voluntary control, it's an automatic control, which is tracking. When the instrument leaves the field of view, then the endoscope automatically tracks the system. Okay, so we have these 5 control modes, and we wanted to see what potentially they can bring to a surgeon. So again, I want to recall that this video is a fake video. So it's acting, and then the movement of the endoscope is manually controlled by one of the researchers. And the objective was to interview 6 surgeons from 3 different hospitals and 3 different specialties. And here is what we got as a first result for this first step of evaluation. So here you have the tabular visualization where the size of the box, the total box, represents the mean value for the answers to the 7 criteria. So the 7 criteria are: whether do you think the control will be stable? Do you think the control will provide fluidity of the movement of the endoscope? Will you be able to have a movement economy, to use less movement or more movement? Do you think you will be able to realize high amplitude movements? Do you think you will be precise? Do you think it will be a high mental load to use this control mode? And do you think this will be intuitive? So again, it was a small set of surgeons. So we were not here to give statistics, but to see tendencies. And the tendencies, in fact, were very clear. And interestingly, hand manipulation was what was definitely preferred by all the surgeons, meaning that it is okay for me to release the instrument, grasp the endoscope, move the endoscope, then release the endoscope still, and continue the surgery. They thought that would be simple, intuitive, and etc. Then tool tracking, which is the automatic control mode, not the voluntary control mode, was the secondly preferred control mode by the surgeons, and the other ones were less preferred, like the voluntary control by an interface. And we could feel from the several discussions and the interviews that we had open interviews at the end of the sessions, that they had a fear. For example, in posture tracking, they had a fear that they would involuntarily move, provoking a movement of the endoscope that was not intended. So there was something that they really would not want to do. So, okay, so we had that interesting result, and we also wanted to mention that the interest of the controllers were different when we were talking about different phases of an operation. Some phases require stability and very little movements of the endoscope, adjusting movements. Some phases require very large movement of the endoscope, and of course, the control is not appropriate for all the different phases of a procedure. Now, what we did is, okay, let me just stop this. What we did is a second study. So the 3 best control modes according to the first phase were used and implemented, really implemented on the surgical cockpit in such a way that we could give this to the hands of surgeons, and they can try doing exercises that are standard exercise for laparoscopists, and giving their feedback on how well the control of the endoscope was. So we kept 3 modes: the hand control mode, the tool tracking, which is automatically tracking the tools with the camera. Let me just have this continuing. So here you see the hand manipulation. Okay. Now you see the second mode is joystick. So you have 2 hands holding the instrument and an endoscope moved by the robot. And here you can use a joystick. Whenever you push the joystick, it will move the system. And now the tool tracking is whenever this left instrument quits the center of the image, then the view is automatically adjusted. Okay. Now, we also considered 6 different exercises. One is exploration of the whole workspace. One is object insertion, so inserting an object through one trocar, just like this. So this is, here we show illustrations with different control modes. We had endoscope cleaning, focused work, which is done here under tool tracking. And we had finally anastomosis, which is suturing exercise. So all the exercises were practiced by all the surgeons for all the control modes. I want to say that this is another group of surgeons as compared to the first group. And here are the results that we got. Again, overall, the manual the manual positioning of the endoscope was preferred. Again, I want to say that the manual positioning of the endoscope is assisted by the robot, meaning that when you move the endoscope, the robot follows. When you release the endoscope, the robot maintains the position still, and then you can use your hand. It's not like fully manual. So, but this mode was clearly preferred overall, except for peg transfer that requires small movements back and forth of the endoscope. And for this particular one, automatic control was preferred because it was very well adapted. Meanwhile, it was not at all adapted, for example, for endoscope cleaning, that requires the endoscope to go far away in the laparoscopic trailer. So we had these results from the 6 tasks and the 3 modes, and they are the mean values, but also we had a particular experiment where they had to do the 6 tasks and they could switch between whatever control mode to see if they would prefer using, if they would by themselves switch or not. The switching was implicit, meaning that they can use all the control modes. They were on, in fact, simultaneously. And whenever you grasp the endoscope, it automatically switches to hand. And whenever you push the joystick, it switches to joystick. There is no need to have an extra button to switch the mode. So what we observed is that during that experiment, the surgeons were mobilizing their preferred mode for each task, meaning that the switching was really, really nice, and it did not give much of new results. But we had some suggestions. We had that question during the first presentation. Did the surgeons give you any input? And in fact, they did. They did some like, hey, you should have an automatic control, but we should be able to switch on and off, or to separate degrees of freedom. We should change that joystick gain or whatever. So we kept that for the future work, and we generally conclude that if the manual positioning of the system is good enough and easy enough to provide, the surgeons seem to prefer that, which is sort of disappointing because we all are searching for means. But one of the conclusions is that probably those teleoperation mode with the joystick or with whatever, or the automatic controller are not well enough integrated into the motor control of the surgeon. And this is why, together with Etienne and other people, we are studying that new concept of movement augmentation. Movement augmentation is not just another way of teleoperating. It's a way of making the user that has to move a device feeling that this device is a sort of a supernumerary limb of its own body and moves it very naturally. And to go toward this possibility, we inspired from prosthesis control. And a first main concept is body compensation in prosthesis control. So what you see here is one of the competitors of the Cybathlon last year, and this guy has to flip over those blue glasses, and normally he should use the pronation supination of his wrists. But because it is too slow, or it is not available, or it is not easily mobilizable, he uses a huge body compensation. So he's leaning completely to realize that distal motion. And what we did in the field of prosthetic control is using these body compensation as a signal to control the prosthesis. For example, in this situation, when we see this guy leaning this way, we are able to compute that the wrist pronation is not correctly positioned, and then we operate that pronation. So, of course, due to the time, I cannot explain that completely, but I just wanted to show you one video to show how it works. So we have this controller that couples in blue the human control system and in orange the robot control system, and they all contribute to the same movement. The prosthesis observes the movement of the user and realizes a movement accordingly by detecting body compensation. So what you can see on the right with the compensation cancellation control is, for example, that the extension of the elbow and the rotation of the wrist are operated automatically from watching the posture of the user. When the user uses myoelectric control, which is voluntary control with EMGs, then you can see that he compensates a lot. You can see that he's leaning a lot, but he does not uses the extension of the elbow because he can do this directly by body compensation. Here, the body compensations are much less because they are transformed into automatic motion of the thing. All right, so maybe what could bother, what is the link between this guy, amputated person with a prosthesis, and a surgeon operating? Then I want to get back to the first video that I've shown. This is one picture extracted from the video that we initially shown to the surgeons. We were offering them to use posture movements in order to control the movement of the endoscope holder and the camera. And they say they did not like it. It was, in fact, the worst case for them. Mostly, they were scared of moving their body without the intention of moving the endoscope, which is a problem. But then we say, okay, but if we are sure that what you are doing with your body is linked to the motion, and then they said, in fact, we don't like this because we are scared of a musculoskeletal disorder. If we need to lean this way to move and to lean this way, we cannot stand for long in that position. And then one or two added this interesting remark, which is, in fact, we do this naturally. A lot of young surgeons, when they want to see what is happening here in the left side, on the, they would like to see here more precisely, they would naturally do that movement, just like if they would like to enter the image and see what is happening. And so we had the conclusion, and we were able to observe that in a surgical theater, that they are naturally trying to compensate with their body when the view is not exactly the one they want. So if we have this hypothesis that the postural compensation does exist on surgeons, we would be able to use it, measure it, and connect that to the motion of the endoscope, similarly to what we have done with prosthetic patients. And the way we are going to do that is to create a virtual supernumerary limb that is connected to the body virtually connected to the body of the surgeon and connected to the endoscope holder in such a way that we would like this guy to have the impression having a third limb manipulating this, just like if it was a prosthesis. Of course, we are not yet at this, but we already started that example to show that we can do three-hand manipulation with a virtual limb. Excuse me, let me just get back to the beginning of the video and explaining you what is happening. So here we have Alexis Poignant, one of our students. He has a augmented reality headset, and he has here a rigid body attached, whose localization can be computed in real time with respect to his body and his head. And there is a virtual arm connected to this body and going here up the shoulder and in front of him. This virtual arm is visible through the headset, and this is what you can see here in blue. So in a few seconds, he will turn the head, and just to show us what he sees, he has this extra body here. Now, at the end of the extra body, there is this blue sphere, and there are two green sphere that he will be able to grasp with the hands. So virtually, he will grasp the sphere with the hands. And now that's a 1, 2, 3 hand manipulation. And his objective is to put those 3 spheres into the 3 spheres over there. Meanwhile, we have 9 different degrees of freedom thanks to the passive joints that are implemented in this object. It's not a rigid object, it's an articulated object. So to control those two, the subject uses the hands, and to control this one, the subject uses a virtual arm, and attached to his body, he will move the body, and we will, to compensate for the lost mobility, because it's real mobility, and we will control the mobility of the limb accordingly. So here is how it works. So now he grasps the 2 things, so he can manipulate to the correct position, both with his real hand and with his virtual hand. So what you have to understand here is that the control of those 3 spheres is independent. There are 9 degrees of freedom. And you may observe here for different movements that there is like a central posture, moves the postures and get back whenever the convergence has been obtained. So again, the controller that is used here is exactly the same controller that we've been implementing for prosthesis, showing efficiency in prosthetics task. And our hope is that we will be able to, by the previous system, to use this virtual system not to grasp a virtual object, not to grasp, not to perform virtual tasks, but to perform real tasks, thanks to a virtual connection. Now, I guess it's time to conclude. So, a first conclusion from our first study is that surgeons seems to always prefer using their hands than teleoperation if they can reach the system. So this is really the main lesson from our study. And this is why trying to build a third hand, a real third hand that is really incorporated into the motor control systems, things of great interest. And for this, we are aiming to develop a mapping between the body motion and the system motion that is a closed loop system pertaining to what we call the compensation cancellation control. And then I'm done with my presentation, and I would be ready to answer questions if you guys have any.
Thank you. Could I ask a question?
Yeah, sure.
I'm very glad to meet you through the workshop. So your talk is very interesting. So I have a question about the autonomous control of the surgical robot. Because in autonomous control, surgeons don't need to do many things. They definitely reduce their effort. They can take a rest. But it seems the surgeon didn't choose it except the pack transfer task. So what do you think is the biggest challenge to develop the autonomous control for the surgical robot?
So what Jan-Pei, do you want to know which automatism should be done, or what, or in general?
I want to know what's the big challenge for the autonomous control is intention identification of the surgeon, or the uncertainty of the surgical environment, or the others, or what?
Well, okay, so automatic control was the second selected okay, apart from hand manipulation that they prefer because this corresponds to their practice. Among the robotic modes, automatic control, what they initially they say, oh, this is super, I want it, I want to try it, it must be really nice. But then one of the main problems they reported is when they actually tried it, is the fact that if you do instrument tracking, so when you move the instrument, then the camera will follow just like this, you know. And then they realized that in some of their movements, they would like to reach the limit of the image without having the endoscope moving. So in fact, a big question is how to have the system automatically understanding that the gesture corresponds to a movement in the scene that should be followed by the endoscope, or it's just going at the limit of the image without this. So surgeons suggested that they should have a switch, like a pedal or something. But then again, it's a new order. And in terms of human-computer interaction, it is known that if you have switched between different states, the risk of not remembering what is the state is high, meaning that at some point it will be on and you will think it's off and then you will still move. So the problem of switching in human-computer interaction is to ensure that the user always knows what is the control mode.
Yeah. Thank you. Thank you very much.
Yeah, that's interesting because we thought more for autonomous. So we thought that if you would like to make the robots understanding what you want, yes, but then you would not need to notice what the robot is doing. But you seem to say that you need to be able to monitor what the robot is doing.
Well, it's either the robot understands 100% what you are doing,
yeah,
and then it's fine.
Mm-hmm.
But if there are then you need to have the feedback to secure the dialogue between you and the robot, or the situation
Mm-hmm.
awareness.
Yeah. Yeah. Ideally, so the control would become, so you would have feedback, but the control would become so good that you would be able to neglect it because it would do what you want. Yeah.
Yeah. But then, then in that case, what surprised us is that they seem to be okay to not have the voluntary control. I mean, to couple because in fact, for example, the impression that you have is that the system is autonomous when it's in automatic control, and it's not. It's something that they must accept, but we thought it would be a problem, but in fact, they have no problem with that, providing that they project a 100% error-free behavior.
Okay, the surgeon also do not have any problem with that.
Yeah,
that's great. Yeah, that's great. And a bit unexpected, yes. Okay.
Can I also ask one question? Thank you for the interesting talk. So with regards to the approach of the surgeons and preferring using their hand, how do you think their previous experience and basically being used to use the hand might affect the results? And if this experiment was done with like maybe medical students, would the results be any different?
yeah. It would. You probably noticed that all the surgeons were decently experienced. Some of them were very experienced. So you're right. This would probably change a bit. Of course, we don't have like statistical quantitative analysis at this stage. So, but probably it would change a bit. But it's not only a matter of being used of it. It's because of the concept of the surgical cockpit that you are on the patient. You are not distant. So really, it's here. It's like next to you. So it's very natural when you want to move it. If you want to provide an interface that is more intuitive and more used than just grasping, moving, and getting back. It needs to be very intuitive and very, easy to use. Any small difficulty to use it will probably be a problem. And now that is a good option, and then I think Jan-Pei will talk a bit about that. But it was eliminated in our study, not because it's a bad option. You've shown that it has good possibilities, but because the surgeons say that they are using tools and imaging systems that already requires pedals, and they say, oh, the feet are not free for those targeted applications. So in the previous in the preliminary discussions, we had a no for the foot pedal because of the specific equipment they are using in their surgery.
I see you're muted.
Yeah. Thank you very much.
Unmuted, sorry. Thank you very much, Guillaume. Thank you so much. So Jan-Pei, are we continuing?
I'll be
Thanks.
the next speaker.
Yeah, thank you, Guillaume. So this is the presentation of Jan-Pei now.
Okay, so I'll be the last speaker. So hello, everyone. Very honored to join this workshop. So my topic today is design and evaluation of hand-free body interface for robotic surgery. So for the background, so the other speakers already talked more, so I will use less time. So robotic minimally invasive surgery can be divided into laparoscopic robotic surgery or endoscopic robotic surgery. So laparoscopic robot is use a rigid body, and the surgeon will have small incisions on the patient's body. And the endoscopic robot is use a flexible body, so it can access to the surgical area through the natural orifice. And for both endoscopic or laparoscopic procedure, normally more than 3 tools are needed in the surgical operation. So this slide has shown some surgical scenarios using 3 surgical instruments. For example, the third tool could be the laparoscopic camera to provide the view, or the flexible endoscope to enlarge the workspace, or it could be the suction tool to suction the blood when the other 2 instruments are doing cutting or suturing. Or the third tool could be the screw to make the organ in a good orientation to expose the surgical area. So in general, there are several operation strategies to control 3 surgical instruments in the current practice. So one is still using the cooperation of 2 surgeons, like a master system. So one surgeon is controlling 2 endoscopic instruments, and one assistant is standing at the patient's side to control the flexible endoscope. So the communication error between them is inevitable. And another way is using separate hand interface to control the third instrument, or using the same hand interface to control different surgical instruments by pressing the clutch buttons or pedals to activate the tool swapping. For example, the Vinci system, K-Flex system. But this control strategy are using the sequential bimanual operation, so it's not possible to move 3 instruments at the same time. And the third way is using the hand-free control. It will let surgeon control 3 instruments at the same time. The third hand could be the head movement, voice command, finger movement, or foot movement. So this control strategy have the benefits to freeing surgeon's hands. So, but when using this control strategy, we need to design the hand-free body interfaces. So to design this kind of interface, we should satisfy some requirements. First, the selected hand-free source is better to independent of hands, eye, and speaking. Then it's not affect the mean operation, visual feedback, and communication in the operation room. And secondly, the input signal should be easier to be detected with less noise. And thirdly, due to the limited workspace in the operation room, the interface is better to have a compact structure. And fourthly, the interface will be used to control the tools like laparoscopic camera, endoscope, or the other third tools. So those instruments are normally require 4 degree freedom or more. So the interface is better to control multiple degree freedom. And in addition, the control strategy should enable the surgeon to control the third robotic arm without increasing mental or physical effort. And in robotic surgery, the surgeon is in a sitting posture, so their lower limbs are free to move in multiple degree freedoms. So then we'll next use a foot control as an example to talk about design and evaluation of the hand-free interface to control a surgical tool. So based on the requirements, we have selected 4 degree freedom foot gestures based on human biomechanics. They are the foot left, forward, backward, horizontal translations in 2 degree freedom, and the foot yaw rotation and pinch rotation. So the up and down vertical direction and the roll rotation are excluded due to the human fatigue or small motion range. So to collect these foot gestures, we locate multiple feedback and sensing modules around the foot. Each sensing module is a set of serial connected elastic element and force sensor. So we use force sensor instead of position sensor, as the force sensor could still record the force at the boundary of the position workspace. Then this avoid the ceiling effect of the input signal. And the elastic element could provide the operator some passive haptic feedback, then help the operator to position their foot without the help of the visual assistance. So when it comes to the detail of the design, we have used a parallel serial mechanism, and the serial pedal is embedded into the parallel base to keep the interface in a compact structure. And the pedal plate, it will support the leg against the gravity in order to minimize human efforts. And the adjustable foot fixture could fit different foot sizes, and the interface can collect 4 degree freedom natural foot position and force signal. So we have the design of the interface. Then in the later section of this presentation, I will talk about the evaluation of the hand-free interfaces with 3 experimental studies we have conducted. So first, the foot interface has been tested to teleoperate an industrial robot with a user study of 10 subjects. We have compared the proposed pedal foot interface with existing conventional button tap interface and validate his effective motion control in multiple degree freedoms. So here is a demo video show 2 teleoperation tasks. In this experiment, we are these tasks are defined based on the laparoscopic training. So the first task is a spatial targeting task, and the operator uses a foot to control the robot and the effector to accurately press a small LED button. And the second is a pass following task, and the participants could follow a curved path accurately. So we found the pedal interface can work well, especially in the circle trajectory, because the operator can directly control multiple degree freedom in one move, which is a natural way of human motion, rather than move in 1 by 1 direction or the button interface. So we evaluate the human performance using the objective measures like error rate, motion smoothness, and the operation time, and also the subjective measures of questionnaire. So for error rate, both interfaces have similar results. And the button interface is still superior in movement of single directions. And for the motion smoothness and time, so pedal interface is better than the conventional button interface. And the questionnaire result also shows that the subjects feels the pedal interface has relatively intuitive mapping and comfort operation. So then in the second experiment, we further check whether the interface can be used to control our surgical instruments. So we develop a foot-controlled robotic endoscopic system, as shown in this slide. Through this system, the user could remote control a flexible endoscope using their foot to control the endoscope remotely through the camera view. So the robotic system can be integrated with a commercialized endoscope. Through the left video, so you can see the endoscope can be easily and quickly mounted or dismounted from the robotic system without any modifications, with just a few steps. And the mapping between the foot and the flexible endoscope is quite straightforward. So as shown in this right side video, so the operator can imagine his toe is the tip of the endoscope and conduct corresponding movement. So this isomorphic mapping is intuitive and easy to learn. So all the participants can quickly become familiar with the foot control without difficulty. So in this experiment, we compare the proposed foot teleoperation scheme with the existing hand teleoperation and the direct control. So in direct control, the operator manually controls the endoscope at the patient site using his built-in dials. Then they use one hand to grab the control section and use the fingers of this hand to rotate two control dials. And the other hand is holding the distal tip. So this control mode is a conventional approach to maneuvering endoscope in the hospitals. And the hand teleoperation is the most common way to teleoperate robotic system. For example, Da Vinci system, Flex system. Well, both hand and foot teleoperation use robotic system to move the endoscope remotely through a hand or foot interface respectively. So we have used endoscope locomotion task in this test, and the participants were asked to control the endoscope to 5 special targets, and each operator was required to perform the task using these 3 control modes with a random ascent procedure, use the same endoscopic view. So the result is evaluated use the operation time and the questionnaire. So from the questionnaire result, the direct control was felt non-intuitive compared to hand and foot teleoperation, and foot teleoperation was felt to provide more comfort and less fatigue than direct control. And the subjects also felt the hand and foot teleoperation has no difference in all the subjective measures. And the operation time results show that both hand and foot teleoperation are more efficient than direct control, and hand teleoperation needs the least time. So this result is expected as hand is the limb normally used in daily life. But when using hand, we can't control 3 tools simultaneously. So the bimanual sequential control may not that efficient compared to the hand-free operation in 3-hand surgery, which we will test in the 3rd experiment. So we finally performed the last experiment of 3-hand surgery using a 3-limb teleoperated system. So the system provides one surgeon to control 13 degree freedoms of 3 surgical instruments. The foot is still used to control the flexible endoscope. At the same time, the hand are used to control 2 endoscopic instruments. So in the current system, left hand to control the robotic grasper and right hand is used to control the categorizing hook. So this trimanual hand-foot control was compared with the bimanual clutch-based control. So for the 3-hand control, we still use the foot interface and 2 hand interfaces. And for the clutch-based control, we'll use 2 clutch buttons attached to the hand controller. So pressing them could allow the operator to swap between the endoscope and endoscopic instruments. So here's a demo video of the surgical task. The operator will ask to cut the tissue at 4 targets, including 2 exposed targets and 2 covered targets. And the foot-controlled endoscope not only provide the vision feedback, but also act as a transport tool to load the hand-controlled instrument to a relatively large workspace. So for the exposed target, the user can use the endoscope to the rough position and use a hook to cut the tissue. So for the covered target, you can see from the video, the user will need to control all the 3 tools in a coordination way. So the endoscope is used to enlarge the workspace, and left hand to lift up the tissue, and right hand cutting inside. So the result of this test verify our assumption that 3-hand control is efficient than bimanual sequential control in a surgical task. And the operation time was reduced using 3-hand control compared to clutch-based control. And most of the subjects also feel that the mental effort required for the operation using the hands and foot is lower. So we currently continue our 3-hand surgery with using the Vinci system in laparoscopic surgery. So here is a demo video showing about how the foot interface to control one of the Vinci patient side manipulators. So you can see the 4-degree freedom foot motions could be intuitively mapping to the motion of the patient side robotic arms. So now it's showing in the velocity control mode. So the foot position control the velocity of the slave robot. So here is another demo video of the 3-2 operation using foot to control PSM3 and hand to control PSM1 and 2 to perform a 3-hand coordination task. So the foot control tool is acting as a screw inserted into the silicon cube, and its movement could assist the hand-controlled surgical gripper to pull out all the pins quickly. So based on the Vinci platform, so we plan to conduct more experimental studies of 3-hand surgery with participants of medical background, and also extend the operation task to different 3-2 surgical scenarios. Okay, so this is the end of my presentation. So all the interesting contents is contribute to the NEMA project, non-invasive interface for movement augmentation. So if you are interested, you can go to this website to look more information about this project. Okay, thank you for listening. This is the end. So I'd like to take any questions.
Thank you very much, Jan-Pei. So does it have any question? I don't see any question in the chat, but if you have a question, you can put it now.
I do.
Yeah.
Have you part of the whole thing is pertains to a good geometrical mapping between all the different frames where you are in your interfaces and the frames that you have in your in the surgical scene. Have you tried like to see whenever, have you experienced any difficulties in having all those reference frames aligned, or have you tried to see if the whole thing is robust to misalignments or small misalignments?
Now I use the foot position directly control the Cartesian position. So for the laparoscopic robot is actually ready arm, so it's kind of like the human leg. So human just can imagine his leg is leg is a laparoscopic tool and use the foot as the end effector, the same as the end effector. So the motion is actually similar for the leg to the laparoscopic tool. And for the endoscopic robot, actually, I found there's 1 degree freedom is not that intuitive. For example, the row direction, because the current interface, we don't have the up and down direction and row direction. So for this mapping, we found this degree freedom is not very intuitive. So, so my future, one of the future direction is maybe develop 6-door foot interface to check whether foot can output more degree freedom.
All right, thanks.
In general, so also for the work Jan-Pei did in the PhD, so she looked at what seemed to be intuitive mapping, right? That things you have to try by yourself, and of course you should also some experiments. Doesn't have to be systematic experiment, right? But try a bit what looks intuitive. Now, in general, when you have a fixed mapping, and that is not too unintuitive, I would say, we human are pretty good in making some transformation and learning it fast. So that's not something that that seems to be a big problem for us. So I don't know in 6DOF, but in 2 and 3DOF, so there are quite a few studies in that, and basically you learn pretty fast to do the transformation. Again, assuming that you do not choose a too bad mapping. Of course, I mean, what does mean too bad? You have to try, but yeah. And even, as you know, even forces, that's something you can also adapt to very, very fast. I have a question. So both for the soft endoscope and for the Da Vinci system now, so so is the 4DOF of your current interface enough or not? And second question is, would the second leg be useful at all or not at all?
Actually, second leg, because in robotic surgery, that leg is used to control the categorizing, activating the categorizing hook. There are another pedals in robotic surgery to activate the knife. So I'm not sure whether if that foot also used to control the motion or how to control the other activation of the tool. And for the 6DOF, so 6DOF, 6-degree freedom, if to control the laparoscopic camera or flexible endoscope, 4-degree freedom is enough. But if you want to control the laparoscopic gripper of the Da Vinci robot, because it have an endowice system, so that tool has 6DOF. So if we want to control that, 4-degree freedom will be not enough.
Okay. We got a question in the chat. So the question is from Jimmy Da Silva. Thank you for the great presentation. How long was the last presented experiment for one participant, and did any participant report knee pain?
Okay, thank you for your question. For the last experiment, most of the subjects can finish the task within 10 minutes. So for the knee hurting, actually we have used velocity control, so the foot don't need to hold in there. So you just move to the desired direction, desired position, and if they want to hold to that position, the foot will just go to the middle position and take a rest, and the hand can do the operation. So the subjects didn't report the knee hurting.
But there is also that that your interface is supporting the, yeah, that's something to note. I mean, maybe you told it, your interface is supporting the weight of the leg. So and if you release the leg, it's coming back to the zero position, to the reference position. So from that point of view, there is not much fatigue in principle.
Yeah, it's a kind of like a, you can take regard it as a foot joystick.
Ella, in your current interface, you have also that the leg is supported for gravity, right?
Yes, that's right. So it's important to think about the fatigue of the foot, and yes, the foot is supported. I also have one question from Yongpei. Thank you, Yongpei, for the presentation. So in your interface, are you using coupled control of the degrees of freedom, or is it like decoupled control, like one DOF at a time?
For the last pinch rotation, it's separate. For the other 3-degree freedom, horizontal movement and rotation, that is coupled together. It's a parallel mechanism. Mm-hmm. So we use SA to decouple to find each components.
So did you have any feedback on this? Like how was it perceived? Was it any comment about like whether having it decoupled might be like better or harder, or any feedback on that?
Do you mean the structure of the interface or the?
Yeah, so I guess my question is mainly about the thought of the participants. If they found this approach like easy to control, and if they could predict the movements of the interface, since 3 DAF were controlled at the same time.
Yeah, so we will let the subjects do a calibration procedure first. So we'll check their specific degree motions and decouple using their own data. So for the structure, I think the parallel structure now is have a very compact mechanism, because in the operation room, the workspace is very limited. So I think the parallel structure is relatively better.
Yeah, thank you.
Any other question from the participants? Jan-Pei, do you have any comments, or do you want me to conclude? What do you want to conclude?
Yeah, maybe you conclude. I think it's already the time to finish.
Okay, then I conclude. So thank you so much, Elahe, Guillaume, and Jan-Pei for the great talk and for the discussion. Yeah, so this is a topic that is in development, and so it seems that current surgical robots do not use the foot control very efficiently, I would say, from a motor control point of view. So, for example, so having switching a button like LIA showed, or Jan-Pei at the beginning, doesn't seem to be a good solution. So there is, I think, a lot of experimentation necessary, and to try to develop these techniques and to see also the limit, to see what is not possible. And yeah, I hope we get interaction, a lot of interaction with surgeon to actually develop systems that they want to use. On augmentation, movement augmentation, so for surgery and for maybe many other kind of application, as Jan-Pei mentioned, so you can follow, if you want, the activity we have within the NIMA project, and the NIMA website will show what we want to do, and you can interact in that. One initiative that we will have very soon is that we will have a series of lectures on movement augmentation with great people from robotics who pioneered this field of movement augmentation with supernumerary arm, and also people from neuroscience who work on understanding how the brain can control or could control such movement augmentation. And I thank you for your participation. And if you have any question, please, so you can, of course, address directly to the speakers, or you can pass them to Jan-Pei, who will forward them to relevant people. And I thank you very much for your participation, and I look forward to seeing you in person. Bye, Guillaume. Bye, Lahe. Thank you.
Bye-bye.
Thank you, Jan-Pei, for organizing that.
Thanks.
Bye, thank you.
Thank you very much. Bye.
Thank you, Marianne, also for the infrastructure.
Yeah. Perfect infrastructure.